From the Oxford University Global Surgery Group, today's theme is NDORMS and Orthopaedics. The NDORMS group has concentrated their talks on fractured hips in Asia and Southeast Asia. And we have two speakers. One is going to describe the qualitative part of the work, and one will describe the quantitative part of the work. The two speakers are Dr. Goh and Ms. Grace Drury. Dr. Goh is an academic clinical foundation student in the NDORMS. He's currently a PhD student with great interest in fractured hips, and that's what he's going to discuss with us. Grace Drury is well known to us in global surgery. She's part of our team. She's currently a global surgery project manager, and she's worked with Chris Larvey for over 12 years, working on teaching, training, and project work with the research products in tow. She's got a double master's, one in English and one in international development. So I'd like to leave the floor for Dr. Goh to start off his presentation.
Good morning, everyone. Thank you very much for the kind introduction, Prof. Laku. Before we go into the hip fracture talks, I'm just going to give an update on behalf of the Global Surgery Group, for those of you who might be new to us. So we're an interdepartmental group representing 4 departments in the Medical Sciences Division. We span surgery, obstetrics and anaesthesia, with a real range of members from consultants, students, trainees, and researchers as well. We're interested in training and research and capacity building health partnerships. We also have some global surgery fellows, academic foundation programme doctors and student representatives. And we're involved in the 4th year medical education here with the Global Surgery Special Study Theme module. Our 4 lead faculty represent our different disciplines. And our aims are advocacy, supporting clinical, educational and research activities in our different areas, and to be a resource as well to our colleagues here and overseas. So we are in the middle of our 4th year medical student module on global surgery, giving an introduction to the evidence for the needs in global surgery, anaesthesia and obstetrics, and looking at examples of projects that are trying to tackle this inequality. Students have an opportunity to do their own project, and if they want to take it further and do presentations or posters or publications, we work with them as well. An example of one of our successful partnerships is with the Chittagong Research Institute for Children's Surgery, and this came out of a network with the Global Initiative in Children's Surgery, and it has enabled us to really advance research, education and policy development internationally for children's surgery. And developing a more formal partnership has been able to lead to new projects and new outputs to be able to share learning globally as well. I'm just taking you through our activities the last few months. In September, we held our annual global surgery course here in Oxford with students from across the world. It was a really exciting week of looking at all different areas of need in global surgery. And our next course is this coming September. We'll be advertising or opening applications soon if you know of anyone who might like to spend a week thinking about global surgery, anaesthesia and obstetrics. And we do have some bursaries available as well for those applying from low and middle income countries. An example of some of our advocacy activities, our team went to the House of Lords in November. Prof. Laku was speaking on children's surgery, and out of this has come some really interesting discussions and opportunities to advance advocacy for children's surgery to make sure services are more available. Dr. Edgecombe ran the Oxford Global Anaesthesia course last November in Uganda. This is an accredited course which was attended by 18 delegates from across the world, trainees and consultants together. And this is a great preparation course for those who are looking to spend a longer period of time working in a culture different to their own. We also were part of running some surgical training courses in Cameroon with our Francophone colleagues in November, and this was in partnership with British Association of Paediatric Surgeons. There was a neonatal skills course and a laparoscopic course as well. I understand that most of the paediatric surgeons in this country are women, so it was a great opportunity for to work together with these up-and-coming surgeons. December was a busy month. We supported a surgical course for treating older children with clubfoot in Ethiopia, which was a follow-on from one of our grants here at NDORMS, where we developed training materials. And also, members of our team attended the College of Surgeons of East Central and Southern Africa conference, some as examiners for the fellowship exams, some leading surgical training courses, and also Prof. Lavi was awarded an honorary fellowship. This week, there's been a limb reconstruction course at Cure Children's Hospital of Zimbabwe, which has been a long-running partnership with University of Oxford. They're very much up and running now, treating children and also involved in different types of surgical courses, which we've had opportunity to partner in. We meet weekly on Thursdays at 8 o'clock online on Teams, so you're very welcome to join us for seminars, project updates from the team here, and also from invited speakers. And you can find out more on our website. Thank you very much. So I'd like to hand over now to Dr. En Lin Goh.
Thank you very much, Grace. Thank you, everyone. So my name's En Lin. I'm a registrar in Trauma and Orthopaedics, and I'm undertaking my DPhil in hip fracture care with Professor Matt Costa. So today I'd like to present some of our work that relates to the service availability and readiness for hip fracture care in a few countries in South Asia and Southeast Asia. And hopefully this will set the scene for the next talk on HIPCARE. So there's been an increase in the number of fragility fractures in low and middle income countries as a result of population aging. We see the regions of South Asia and Southeast Asia as most affected by this demographic shift. And we expect that the number of hip fractures in this region is going to double over the next 20 years. And this places a substantial strain on the healthcare economies of these countries. Now, before I go further, I'd like to share the patient experiences of those who've had a hip fracture in these low middle income countries. I think it gives us a bit more insight into their perspective. So I'm just going to pause here for a moment and load up some of the quotes for everyone to read and peruse. And I think this really highlights the challenges that these patients face in these low and middle income countries, especially when it comes to the setup of the healthcare system there. And probably reinforces the importance of why we do what we want to do, which is to improve the standard of care, not just here in the UK, but also around the world. So how does it work in terms of care pathways? Well, in the UK, we have successfully mapped care pathways through hip fracture registries, such as the National Hip Fracture Database. And this is similar across other high-income developed economies. And the mapping and the data that we generated have helped us to identify quality standards. And these are specific aspects of patient care that have been shown to contribute towards improved quality of life, reduce mortality, and also reduce healthcare cost. And examples of this that we have strong evidence for are timely access to surgery, joint care between an orthopedic surgeon and an orthogeriatrician, and also early mobilization with physiotherapy. And these have been shown to have a meaningful clinical benefit. But can we translate our work and our understanding of this to low and middle income countries? Well, a main challenge is that such care pathways are poorly defined or not defined at all, and practically non-existent in a lot of countries. And it's therefore impossible to identify any meaningful quality standards and meaningful aspects of care that we think could contribute to positive outcomes. And so we can't set any bespoke quality standards in that sense. So it's important to understand how these systems are set up and what they have available to them if we want to intervene and implement any change or interventions and monitor this as part of research. We use the WHO Service Availability and Readiness Assessment Tool as our framework for our questionnaires, and we distributed this across our fragility fracture networks in Malaysia, Nepal, Philippines, Sri Lanka, and Thailand. And we looked at analyzing data and collecting data under 3 specific headings. The first one was service availability, which we looked at the number of hospitals per capita of the population. We looked at service readiness, which included available amenities, services at each hospital at a facility level. And we then looked at service-specific readiness, which was how prepared the service was to deliver hip fracture care. So this table summarizes the characteristics of the countries that were included. And we have a nice spread. We have Malaysia and Thailand, which are upper middle income countries, Philippines and Sri Lanka, which are lower middle income countries, and Nepal, which is the least developed based on the OECD definitions. And what we see is that there's variations in how these systems have come about and how they evolve with time. For instance, in Sri Lanka, all hospitals that responded to our survey were fully publicly funded, whereas in Malaysia, Malaysia had the lowest proportion of public to privately funded hospitals at only 30%. We also see that there's a discrepancy in how hip fracture care may be implemented across the country, with most hospitals, apart from Sri Lanka, reporting that there was not a lot of similarities in care. And a lot of this really boils down to the fact that there's no established framework and a lack of clinical guidance as well. Now, we wanted to look at service availability, and we use the number of hospitals per capita as one of our measures for this. So this graph shows the number of hospitals as well as the population size, and there should be some bubbles which should appear, which have not appeared. So what we can take away from this, really, and I do apologize for the graph, is that most hospitals have a low number of hospitals per capita, especially when compared to developed economies. And this is about 3 to 4 times lower than other high-income countries within the region, such as South Korea and Japan. And this suggests that there may be potential issues in terms of delivering care at the current level, but also with projections going forward, this is going to be a significant issue going forwards. We then wanted to look and to map the patient journey from the time and the point of their injury towards them receiving treatment in hospital, as this would give us an idea of how ready the service was. And what we see here is that in the Philippines and Nepal, some patients take over 24 hours to present to the hospital after injuring their hip. And this is very different to what we see in the UK, for instance, where most patients present within hours of their hip fracture. We see that Thailand, Sri Lanka, and Malaysia have similar data to what we would expect, but the Philippines and Nepal do stand out amongst this. In terms of time from presentation to admission, most countries, patients were admitted within 6 hours of presenting to the hospital. And again, this compares fairly with our developed healthcare setups. But what about time from admission to surgery? So what we see is that there were delays across the board for all countries. And in fact, patients routinely did not have surgery within the first 36 hours of presenting to the hospital. And the dotted line shows the 36-hour mark, which is the routine quality standard that we use here in the UK to measure our performance. We see that practically none of the hospitals here met these criteria. And when we looked further into one of the reasons for this, what we found was that this was due to issues in service, such as the availability of clinicians, so surgeons, anesthetists, as well as availability of equipment. So When we synthesize all this data, what can we take away from this? So we know that a few weak points in the system are time from injury to presentation and from admission to surgery. And this really compares with, economically developed healthcare systems where patients present within hours of injury, so we focus our emphasis on minimizing delays from the time of presentation to the time of surgery. But it's quite clear that this may not be applicable, and such quality standards do not apply in these healthcare setups because a majority of the delay may arise before the patient even presents to the hospital. We then went on to look at multidisciplinary team involvement, and this was how we wanted to assess the service-specific readiness for hip fracture care. And routinely on this graph, we see all the specialties that would be involved in the care of a patient with a hip fracture. So orthopedics, orthogeriatrics, physiotherapists, dietitians, and so on. And we see that this graph shows what it's like for Malaysia. There's practically minimal orthogeriatric involvement or any specialized form of nursing. This is what it's like for Nepal. Again, mostly orthopedics and physiotherapy, but not much of any other service. This is for Philippines, Sri Lanka, and for Thailand. And what we can take away looking at how all these services are distributed is that there's really not much orthogeriatric care or any other specialized care involved. And one of the reasons for this is that geriatric medicine as a specialty does not exist in a lot of these countries. And so there's no orthopedic or orthogeriatric specific care that's oriented towards this. And taking this forwards, it emphasizes the need to look for alternative medical expertise when it comes to delivering the same standards of orthogeriatric care that we would expect in our system. We focus on mobilization and access to physiotherapy. And what we see is that in most hospitals, patients are typically mobilized on the first day post-operation. Certain proportions of hospitals did not have sufficient physiotherapy services, which emphasizes why they did not mobilize their patients. So this gives us a measure of how much access they have to physiotherapy and the level of service available. But looking further into this, we wanted to see what weight-bearing protocols were, because we know that these factors contribute towards better rehabilitation in terms of recovery of mobility, function, and quality of life. And what we see is that there's significant variation in practices of orthopedic surgeons at different facilities. So in most cases, patients, less than half the patients will be fully weight-bearing after the operation. And this is very different to the standards of practice that we have here in the UK, where patients routinely weight bear fully after the operation. So there's two things to consider here. One is getting patients mobilizing early, and the other one is getting them to mobilize fully weight-bearing early here, that we see as a shortcoming. So in summary, what can we take away from what we found? Well, in terms of service availability, we see that the levels of healthcare facilities for the population does not really meet the current demand, and we think that it's unlikely to continue to meet demand without significant changes. What about service readiness? There's limiting factors, and this manifests really as surgical delay or delay in timely surgical treatment from the point of injury. And factors that we think contribute to this are access to transport such as ambulance services, as well as surgeon availability and equipment availability. And when we focus on service-specific readiness, we see that there is a lack of hip fracture-specific services, such as orthogeriatric care or specialized nursing. So this study has been useful in giving us a bit more insight into the setup of healthcare systems in these low-middle income countries in South Asia and Southeast Asia. We see that the pathways are very different, and therefore quality standards are probably going to be very different to what we see in high-income countries, but also between these countries. In order to identify appropriate quality standards, such as those that we test in HIPCARE, we need to understand current care pathways. And hopefully our work will form a reference point for what we have currently and allow us to monitor this as these pathways continue to develop and evolve with time. Thank you very much. And I will leave up the slide for publication details for anyone interested.
Take questions at the end.
Perfect.
Wonderful. Thank you very much, En Lin. And that's a really important piece of work for us to share, because it's been the most formative piece of work that we've done to develop HIPCARE, which is the clinical trial, which I'm going to give an overview of now. So I'm one of the newest members to this team. I have the privilege of working with many colleagues, both in the UK and in our study countries and collaborating institutions. And it's been a long time coming, this project, and we're excited. We're in the second year of it now, and it's just really getting going. So En Lin's said much of what I'd like to say about why we're doing this project, which is that we know that older patients are more vulnerable to fractures because of their falling, and also the bones may be weakened by osteoporosis, and also mortality and rates are not so good, and also returning to quality of life is difficult for many of these patients as well. We don't know yet so much about the outcomes in low and middle income countries because there's less evidence. As En Lin alluded, we're expecting a large increase in hip fractures over the next decade or so, particularly in Asia, and with a large associated healthcare cost as well. And we know from some work we've done already that multidisciplinary healthcare teams are part of the answer for improving care. And we know that from our research in high-income countries that multidisciplinary teams can help to reduce mortality following hip fractures and improve patients' health-related quality of life, and help to reduce economic costs as well. So HIPCARE is looking at, can we apply this learning in low and mid-income country settings? Is it applicable? What can we learn? And the background is the study that En Lin shared about, which is this survey to map hip fracture services in Asia, and then also the opportunity to apply for funding through NIHR's new Global Health funding streams, where they're quite interested in applying health research for the benefit of people in low and middle income countries, with a focus on strengthening research capacity, boosting knowledge exchange, and building equitable UK and low and middle income country research partnerships. So this is where some of the ODA funding has gone. So our collaborating institutions are in Vietnam and India and the University of Philippines, Mahidol University in Thailand, Kathmandu Medical College in Nepal. We have a team from University of New South Wales, Sydney, helping with our process evaluation, and UK colleagues as well next term. So you could phrase our research question as, can multidisciplinary training and support package, which we're calling HIPCARE, improve the quality of life and reduce healthcare costs for patients with hip fractures? And in our study, we are recruiting patients in Asia, in the 5 study countries, who are 60 years and over, who need hip fracture surgery, and they're available at 120 days for follow-up. So they're contactable in country. So there are going to be 40 hospitals in India, Nepal, Thailand, Vietnam, and the Philippines. They'll be randomized in each country. So 8 hospitals in each country that will be randomized, 4 to control and 4 to the intervention arm. So our plan is to compare those hospitals with the HIPCARE intervention, with the 4 hospitals providing usual hip fracture care in each of those 5 countries, and then look to refine the HIPCARE intervention in each of those countries, and then also see if that intervention helps to improve quality of life and reduce healthcare costs compared with those hip fracture patients receiving usual hip fracture care. So this just gives an idea of the project structure. So we at Oxford are the sponsor. We're receiving funding from NIHR. Our project management group has members from all the collaborating institutions, and across the 5 countries, there's a trial management group in each who are overseeing the 8 hospitals, 8 recruiting hospitals in each, 4 of which are control, 4 of which are intervention. We're supported by the International Scientific Advisory Committee. The process evaluation team are looking at how the intervention is implemented. And we also have patient representatives in our community engagement and involvement panel. So in each of the 5 countries, the trial management group is led by the PI. We've included clinical trainees because we want it to be a research capacity building project that increases opportunities for clinical research. Qualitative researchers, they can be part of the process evaluation and other data clerk, coordinator and IT support as well. This is the sort of thing that I have access to, a dashboard where they can see how many patients are recruited in each country and at each site. And to select and randomise the hospitals, we've had to think about, ideally, we'd like hospitals that are representative of the health system in each country, but realistically, we're looking at ones which are treating at least 200 hip fracture cases per year. These tend to be the university, teaching and public hospitals in each country. But we also need teams which really want to take part in this study as well. So they're interested in these research questions. So we've randomised the hospitals in 3 of the countries so far, and we've identified the hospitals in others that are on the way to randomising them. And these 3 components of the intervention will resonate because En Lin touched on them earlier. So can we improve how the time to surgery for these patients so that it's less than 36 hours from admission? Can we help to improve the time to immediate weight-bearing mobilisation after surgery, so it's less than 24 hours from surgery? And also the time to provide an orthogeriatric assessment to reduce the risk of future falls or fractures. And even if that's not delivered by an orthogeriatrician, it may be by a doctor who has an interest in older patients, but might include some of these components like reviewing comorbidities, their medication, delirium screening and a falls assessment. We hope that would be within 72 hours of admission. So in practice, the intervention is focused on the multidisciplinary team having regular discussions, for example, monthly, and that would be any clinical team members involved in hip fracture care. So not just the surgeons and physiotherapists, but perhaps nurses, anaesthetists, orthogeriatricians, or those in that role. And they would have access to real-time dashboard data for their hospital on those 3 metrics. So they'd be able to discuss month by month, how soon are our patients getting to surgery? How soon are they able to weight bear, mobilise after their surgery and receive an assessment, an orthogeriatric assessment, and look at the trends month by month, think about the reasons for those trends and discuss action points and see if that goes back into the feedback loop of system improvement. The 4 control hospitals in each study country will provide usual hip fracture care pathway. So there's 40 hospitals, there's 40 research study teams, again with a PI, a clinical trainee, so giving more research experience, research nurse, but also in the intervention hospitals, we are inviting a senior clinician to be a champion, so someone who is advocating for hip fracture care pathway improvement, particularly around multidisciplinary teams. So this is an example of how the dashboard might look that the MDT team looks at in each of their meetings. So they can see how many participants have been recruited in the hospital, what those demographics are, the time to surgery, time to mobilisation and time to orthogeriatric review, and look at that. And then we'll provide extra data on the reasons for delays if they want to discuss those as well. So we're following up these patients at 120 days. And the reason that we've chosen 120 days is that we understand from previous research that hip fracture patients often start to plateau in their recovery around this time. And so we're going to use a health-related quality of life questionnaire, EQ5D5L, the modified new mobility score, a questionnaire on resource use to understand the health economics. We'll ask about residential status, any complications, and we'll record mortality as well. So just in a bit more detail, at baseline, we will collect usual participant information about their medical history and where they lived at time of admission. From the medical records, we are to look at what type of hip fracture they have and how they presented, what surgery they had, the card and grade of the treating clinicians, delirium, and then how soon they've been mobilised and got their assessment, what medication they have and when and where they were discharged to. The mobility questionnaire looks at how easily they can walk indoors and outdoors or locally. The house-related quality of life questionnaire looks at 5 different fields from a patient perspective on the mobility, self-care, usual activities, pain, and anxiety, and then scoring their own perception of health on a scale as well, from 1 to 100. I think it might be 0 to 100. And then the health economics form at baseline just looks at a few things. Then at 120 days, we repeat the mobility questionnaire, the health-related quality of life questionnaire. We ask a bit about their medication, any complications they've had, and a slightly more detail in the health economics form so that we can understand the cross drivers. Our process evaluation team are interested in how that intervention is implemented across the 5 different countries. So this is an opportunity for some qualitative research alongside with interviews with the patients, the carers, and the multidisciplinary team and the research study team. And that's undertaken by local researchers, so it will be in the local languages. It's great to be able to have patient perspectives as part of the development of the study, both through the fragility fracture network right from the start, but also setting up local groups in each country who'll be able to give some feedback, both on the research tools that we're using, but also to be part of dissemination and advocacy for improved hip fracture care as well. So we're somewhere in this timeline where contracts and project setup is taking quite a long time for such a new type of clinical trial. Ethics is multi-level across the different countries. We're in the process of randomising sites and finalising the data collection forms. And we've just started holding some partnership meetings in each country. And we hope that sites will start recruiting a bit later this year. And then results will be shared at the end of the project in 2026. So what have we learned along the way about doing something like this? It's quite a complex partnership because we've got 9 collaborating institutions, 5 study countries and coordinating centres, 40 hospitals. The contracts involve collaboration agreements with each institution, clinical trial agreements to think about the responsibilities associated with the protocol, and then downstream agreements with each of the recruiting sites in all these different languages and countries. As it's NIHR funding, which has got ODA funding, there's a slightly different due diligence process we've had to comply with, and think about the ethics and different research governance requirements for each setting. We've got a lot of different languages to think about for translating the different documents. And it's thrown up some really interesting questions about how we're going to analyse the data. So recently our scientific advisory group helped us to think through the statistical analysis plan and the health economics analysis plan. For example, how people might value their quality, health-related quality of life in each of these 5 countries could be different. And so how do you group the data or methodological questions like that? So these are just our institutions. And I think I'll leave it there. I'm very happy to take questions.
Okay, the floor is now open for questions. And I have both of the speakers in front. Take them, coming to the camera view. Good. Do you mind, Chris, please?
Thank you, both of you. Really interesting presentations, great work. I've got a question about people who don't get treatment. Do you have any idea how many people who break a hip in the countries you're looking at who actually don't make it to hospital, can't afford it, and essentially don't have medical treatment?
So I think we know how many people made it to hospital and didn't have treatment, and that probably ranges in the range of 5% up to 30% in some countries. And factors do vary, as you say. For instance, lack of money, lack of resources, as to they can't afford surgery. But I think there's probably a larger number of people who may have broken their hip but not presented to hospital that we do not capture, and it's going to be quite, I think, challenging to capture this data. And what's quite interesting is that from what we see in some countries, we see that the first port of call for patients who break their hip is not the hospital, but it might be non-medical practitioners. And so there are groups of patients who may receive alternative treatments for their hip fracture that we will sort of never really see in our data collection process.
Chris, just to follow on what you say, we've always found in the work that we do that that's the hidden large proportion of what we can't capture. We can only capture what comes into the hospital. And yeah, I think we should start looking at community level work so we can capture them at that level. It's massive, but something we can think about. I have a question that it would be interesting if you could include a high-income country into this, especially like Oxford, the UK, because you'll be surprised on your graphs where Oxford lies and where some of the low-income country do far better than what we do at various levels. Access to theatre or patient communication, clinic letters getting lost. We're not really gold standard and we're not up there. And, if you add this component into the work that you're doing, because you've got it all set up, you'll come out with very interesting answers. And I have some evidence for something that we did in children, and Oxford was not at the top of the pile. So just a comment.
Yes, I think sometimes you can be surprised.
Yes, absolutely.
Yeah. I mean, our statistician for this kind of work that came from Tanzania knew far more on how to deal with it than the statisticians that we have here. So, don't underestimate the value and the knowledge of the people, that they just don't have the resources and the means, but they have the skill. Yeah. Okay, are there any more questions? Well, thank you very much, everybody. This tease for people that are here. And thanks to Matt Costa for leading such a wonderful team. Good, and we'd like to hear your results at the end.
Yes, we'll be back when we've got more results to share.
Yeah, put Oxford in there. I'd really like to see where we stand on your graph.
Thank you.
Thank you very much.
Take care.